Hello, my name is Donna Florkowitz. The problem I will present today is that of healthcare access for people with Medicare. The National Scorecard on U.S. health system performance places the indicator of adults with no access problems because of cost under its access domain. Medicare Part B covers physician, outpatient, home health, and preventative care for Americans over age 65 and for those under age 65 with permanent disabilities. Medicare is funded through payroll and general taxes. In 2010, 31% of primary care providers limited Medicare patients, and in 2011, 17% of providers refused to accept new Medicare patients. Reasons for Medicare non-participation include low reimbursement rates, clerical costs related to excessive paperwork, medical coding, and billing, and a fear of being accused of Medicare fraud. Medicare reimbursement rates are set 20% below provider fees, and balanced billing of patients is prohibited by law. Reduced Medicare funding as part of the Affordable Care Act may further decrease reimbursements and cause more physicians to refuse Medicare patients. There are no current laws that require providers to accept Medicare patients. Access problems are increasing. In 2012, 5.9% of Medicare patients had trouble getting health care, 11% delayed seeking care because of cost, and 11.4% did not see a doctor about an existing health problem. In 2013, 28% of Medicare patients looking for a new primary care provider had trouble finding one. One example of this problem is the Mayo Clinic in Glendale, Arizona, that refused Medicare patients beginning in 2009 because of the $120 million it lost from low Medicare reimbursements. The Centers for Medicare and Medicaid has tried to entice Medicare participation by offering financial incentives to providers for quality measures. The merit-based incentive payment system offers bonuses up to 1.5% based on physician quality reporting, value-based modifiers, and electronic records meaningful use. The sustainable growth rate formula attempted to control Medicare spending. If Medicare went over budget one year, cuts to provider reimbursements were made the following year to recoup the losses. In 2012, Congress suspended a 30% reimbursement cut when 41% of Texas primary care providers said they would stop taking Medicare patients. Sustainable growth did not account for increased Medicare patients or for the cost of new technology. The Physician Quality Reporting System uses the value-based payment modifier for up to 3 quality outcome measures and 6 cost containment measures. There are 284 quality measures to choose from. This top box shows a template for quality outcome measures for acute and chronic conditions and for hospital readmissions, and the bottom box shows a template for provider costs for beneficiaries. Quality and efficient health care lowers costs, which could in turn lead to higher provider reimbursement rates. I am proposing a national health policy mandating providers to accept Medicare patients or face a 2.5% tax beginning in 2018. Access problems to primary care will increase as more Americans reach the age of 65 unless action is taken. The elderly and disabled have multiple comorbidities and need primary care the most. Primary care includes preventative care that decreases healthcare costs in the long run. I am asking for your support for my bill titled A Physician Mandate to Accept Medicare Patients. The Supreme Court upheld the individual mandate of the Affordable Care Act by calling it a tax and stated that Congress has the power to lay and claim taxes. People with Medicare have the same human right to health care as all other Americans. Legislating providers to accept Medicare patients is within Congress's power, and it is the right thing to do for elderly and disabled Americans. Here is my reference slide. Thank you for listening.